Karlsen. I first had the opportunity to meet her many years ago when she was serving as Executive Director of the then T. Colin Campbell Foundation, which now is the T. Colin Campbell Center for Nutrition Studies. Micaela was one of the 2 founding employees of that foundation back a number of years ago, which has had such an impact not only on medical professionals in this country, but in many countries around the world. Micaela is a PhD candidate in nutritional epidemiology at Tufts Friedman School of Nutrition Science and Policy, and she holds a master's in human nutrition from Johns Hopkins Bloomberg School of Public Health and a BA in psychology from Cornell University. And as we've been discussing, she saw the need several years ago to really bring together a curated compilation of scientific documents related to whole food plant-based nutrition when she established plantbasedresearch.org, which is a fantastic resource, and really would urge everyone to visit this and recommend it to their other colleagues. And so we're thrilled that Micaela will be presenting at the 3rd Annual International Plant-Based Nutrition Healthcare Conference coming up in Anaheim in just a couple of short weeks. And today she'll be leading us through a wonderful presentation on the mechanisms of type 2 diabetes reversal. So with that, Micaela, thanks so much for hosting today's webinar.
Thank you so much, Susan, for that amazing introduction. I cannot wait for the conference coming up in a couple weeks. It was such an inspiring event last year, and I'm really looking forward to it. So welcome, everybody. As Susan mentioned, I'm currently a PhD student at Tufts Friedman School of Nutrition in nutritional epidemiology, and I had the privilege of working for Dr. Campbell for many years before starting that program. And of course, when I was working for him, I encountered a lot of people who were successful in getting off all of their diabetes medication simply through changing their diet. And I'm happy that I've had the opportunity since that time to really delve into the research more and to really have the chance to share this with you, because this is something that I think is very important for clinicians as they are considering using a dietary approach in their practice. And if you already are using a plant-based approach as a treatment, you may want to be able to have some of those critical conversations with supervisors or colleagues and be able to explain better the mechanism of what's happening in the results that you're seeing in your patients. So I am stepping outside of my comfort zone in hosting this because I wanted to delve deeper into this research and become more familiar with it. And I'm hoping that what we can accomplish is the same thing for you. So I wanted to start with just a review of the mechanisms of insulin resistance and how type 2 diabetes develops. And we are going to be focusing on type 2 diabetes today, and then discuss some research on the management and treatment for the condition, and specifically these 3 approaches: gastric bypass surgery, caloric restriction, and plant-based nutrition. And the reason that I wanted to include all of these is I've had the chance to become acquainted with this research through my doctoral coursework in my biochemistry. And what I learned that I really didn't know before is that gastric bypass surgery is now quite well known for being able to reverse diabetes. It's quite accepted, and among researchers, the limiting belief, I guess, is the ability of people to stick to a diet on their own. So a less drastic option is often not considered for obese patients because their practitioner, and I think this extends to the research world, doesn't have a lot of confidence that they would be able to stick with lifestyle changes. And it may be that that's true for some people, but I think for a lot of those patients, they're not necessarily aware that there is another option. And if they're presented with that option in a supportive and evidence-based way, a lot of them may decide that they would like to try that. So I think we're going to talk about, and the mechanisms are very complex, and even among the experts, there isn't complete consensus. So we're going to have a discussion, and I hope elucidate some of what is happening at a more mechanistic level, and then be able to share with you this research so that you can share it back with your colleagues. And I do have quite a few papers that I'm going to email after this presentation is over. I think all the references I have in the presentation, I'm going to be emailing you the paper. So not to worry, there's a lot coming afterwards. So I just want to start with some statistics and overview on the mortality toll from diabetes. It's the number 7 cause of death in the US. And there is a split with type 1 versus type 2. Those are the two main diagnoses. Of course, type 1 only accounts for about 5 to 10% of cases. And type 2, which is completely preventable with lifestyle, is really the majority, 90 to 95%. Now, the concern, of course, is not only the mortality from diabetes itself, but also the comorbidity with cardiovascular disease. So among adult diabetics, the risk of death, the rate of death for stroke and heart disease are about 2 to 4 times higher than compared to non-diabetics. And so that's a lot of people, because among adults 20 to 65, 11% have diabetes and about 35% have prediabetes. So of course many people are undiagnosed. But then that really jumps once you're over age 65, so it goes up to 50 and 27% respectively. So that's really a lot. It's expensive. There are terrible complications with reduced quality of life because of the complications such as neuropathy, and eventually many amputations are due to diabetes, of course. So it's a big problem, and the more prepared we can be to offer a diet and lifestyle change, the more empowered patients can be to try to take those steps and avoid some of these outcomes. So the stages of diabetes progression, which I'm sure you're familiar with, are you start with a normoglycemic response, and we're not going to focus so much on type 1 diabetics, but for the most part this develops at a very young age because of an autoimmune mediated reaction in which the body does attack the beta cells of the pancreas, so they are not able to produce insulin. And over the lifetime, type 1 diabetics require insulin for survival, but they do have varying needs throughout the lifetime. So we're not going to talk about this in a lot of detail, but I do think the research that we'll look at here is relevant to this population and to the management of type 1 diabetes, because dietary factors can really play a role in the effectiveness of insulin action, and therefore in the amount of insulin that a person might need to take. And I do know that there's a lot of variation among type 1 diabetics in terms of how much insulin they need. So that's something to think about as we continue our discussion. But with type 2, there's first this normal glycemic response, and then eventually there's either impaired glucose tolerance, which is elevated glucose after a glucose challenge like a meal, or in the case of a clinical testing situation, an oral glucose tolerance test, or there's impaired fasting glucose, which is elevated glucose after an 8 to 12-hour fast. And so this condition of prediabetes can be present for years before the diabetes diagnosis, and eventually this can progress to a diagnosis of diabetes. And initially the patient will not necessarily require insulin. They may just need medication to improve, such as metformin, to improve insulin sensitivity, but this is generally perceived to be a progressive disease without the possibility of improvement or reversal in terms of the secretion of insulin. So that's the general perception. I think that is shifting somewhat among researchers and among maybe clinicians that do use gastric bypass surgery. but I think that's probably still the perception among the public, especially among people maybe that have the condition. So the clinical diagnosis cut points these are from the American Diabetes Association. So for a criteria of diabetes, hemoglobin A1C, which is the measure of glucose attached to hemoglobin in the red blood cells, and this is fairly stable over a several month period. So it gives you a picture of how your plasma glucose has been over the previous 2 to 3 months. Greater than or equal to 6.5% is a diagnosis of diabetes, so any of these criteria can give you a diagnosis. And what I think is interesting about this condition is that it's not really diagnosed based on the abnormality or the disease process that is happening in the body. Rather, it's a diagnosis that is based on sort of the symptomatic manifestation of elevated blood glucose. So the other option is fasting plasma glucose greater than 126 milligrams per deciliter after a fast of at least 8 hours, or 2-hour plasma glucose after eating of greater than 200 milligrams per deciliter. And if you give an oral glucose tolerance test, that's generally 75 grams of glucose dissolved in water, or a patient with classic symptoms and a random plasma glucose of over 200. So these are various ways that you can arrive at the diagnosis, and it's recommended that you do repeat testing, and that if it's anything is equivocal, you do immediate repeat testing. But generally, if there's an extreme result, then it's very clear. So then we have prediabetes, and again, these are the people who are at increased risk of not only developing diabetes, but also increased risk for some of those cardiovascular complications. So fasting plasma glucose between 100 and 125 milligrams per deciliter, or 2-hour plasma glucose between 140 and 199, or A1C from 5.7 to 6.4. And they make the point that really, although there are these thresholds, there's continuous risk throughout this continuum. So it's important to take that into context when somebody is sort of considering what their options are and where they might be headed in a few years if they do have some numbers that look to be problematic. And so again, like, the diagnosis really comes from elevated blood glucose, and this develops in two pathways. There are defects in the insulin secretion by the beta cells. And so when there's continual elevated blood glucose, initially the beta cells will attempt to compensate for this by increased insulin secretion. But if glucose is elevated all the time and they're signaled continually to keep secreting insulin, this can lead to beta cell exhaustion, at which point the amount of insulin that they can secrete starts to diminish. And this is sort of the beginning of the beta cell destruction. And then there are also abnormalities in insulin action. So there are really a variety of signaling mechanisms. One of the most obvious is the GLUT4 transporter is the transporter that enables insulin to get into the cell, and there can be insufficient translocation of that transporter to the cell membrane. So there aren't enough transporters, and the insulin and therefore the glucose is not able to get into the cell. So looking at just a chart to review kind of what's going on. When you eat a meal, your plasma glucose is going to rise, and that'll trigger the release of insulin, which will have a couple different signaling cascades to affect these other parts of the body. So hepatic glucose output is going to go down, which means, when you've eaten and you have glucose in your blood, your liver does not need to produce glucose from glycogen and break it down because you have enough. At the same time, it's also going to suppress lipolysis for the same reason, if you've just eaten and you have glucose in the blood, the insulin will signal, the lipolysis doesn't need to happen. There's no need to break down fat. And at the same time, the insulin will enable glucose uptake into the cells. So all three of these processes together lead to a lower plasma glucose level. And then there's a consequent fall in insulin because of the fall in glucose, which signals the pancreas to stop producing it. However, when you have this impaired insulin action, there's sort of like several things going wrong at the same time. So your plasma glucose does go up after you eat, and your body attempts to normalize it, but several things are sort of going wrong at once. So even though you have glucose in the plasma, your liver continues to break down glycogen and put glucose out, which also increases the plasma glucose. Then at the same time, your adipose tissue, the fat cells, are breaking down fat, and that also increases the plasma glucose in the blood. And then both of these together signal the pancreas to make more insulin, which leads to this vicious cycle. And so when this is happening all the time, which it can be happening all the time before someone's diagnosed or before they have overt symptoms, this is what can lead to the beta cell exhaustion and then eventually the beta cell impairment. So this progression from just the condition of insulin resistance to beta cell failure, it's very gradual, and it really just develops in response to overnutrition and lack of physical activity. And there are a lot of potential genetic predispositions to both insulin resistance and beta cell dysfunction. And I think most of the genes that have been identified relating to type 2 diabetes are part of the beta cells in the pancreas. So what's interesting, though, is that not all obese people will develop type 2 diabetes. There are a significant portion that are able to their beta cells continue to function and compensate for the increased plasma glucose by putting out more insulin. And these people are lucky in a sense. They're able to deal with that. But for the majority of people who have this condition, eventually there's a compensation and then dysfunction and then eventually the beta cell failure. And at that point, that's when there's a diagnosis of type 2 diabetes because of the body can't compensate and the plasma glucose is so high. And then as well, like for most patients and most physicians at that point, the goal becomes not really reversal of that process, but just managing the symptoms and controlling the blood glucose. So there are a lot of different mechanisms by which this happens, and as I was mentioning, if you see on the left-hand side, this is sort of the green boxes are the path to healthy adaptation. So not all of the beta cells will be susceptible to failing or to malfunctioning. Some of them will be able to sustain an adaptation, and for somebody who is overweight but is able to remain metabolically healthy, meaning they're able to compensate for this elevated blood glucose with extra insulin, this can continue for some people for their lifetime. For others, they may be just simply not as susceptible, and then that's where these sort of genetic predispositions may come into play when the system is stressed by diet or lack of exercise, obesity. People respond in different ways depending on sort of what their dispositional weaknesses are. So there are all these possible genetic defects that relate to mitochondrial function and the signaling pathways, and then there are various roles and various different mechanisms that kind of initiate the type 2 diabetes process. And then as it progresses, what's important to think about is once you have reached that diagnosis point, it doesn't just, you're not just maintaining a condition of diabetes, but it continues to progress, and that's why people eventually often need to take insulin. Even though their beta cells may still be producing some amount of insulin, it's not enough because they've such a large proportion of them aren't functioning well anymore. Okay, so that's sort of the background on insulin resistance and beta cell failure. And what I want to talk about now are these two theories about why insulin resistance is happening and how it's happening, and they both relate to excess fat. And this is very relevant for us as researchers and clinicians, because you know, the amount of fat in the diet is something that can be controlled by the patient or by the individual. So there are two theories. One is like a muscle-centric insulin resistance theory, and which is that there's excess lipid in the muscle cells, and that's negatively affecting insulin signaling. So you have increased intramuscular triglyceride content and intramyocellular triglyceride content, and those are both correlated with insulin resistance in humans. And actually, if you increase plasma-free fatty acids for 5 hours, there's a 50% decrease in whole body glucose utilization as well as intramuscular triglycerides. So what we also see is that animal models with increased free fatty acid delivery to muscle, and this happens by overexpressing the lipoprotein lipase in muscle, those tend to get muscle-specific insulin resistance. And then there's also increased intracellular fatty acid metabolites, which lead to impaired insulin signaling. So these are all different mechanisms by which this buildup of fat in the muscle cells is really interfering with appropriate glucose use and appropriate insulin secretion and insulin signaling. And this is a theory that is there's quite a bit of evidence supporting this, but I wouldn't say that among researchers this is definitely accepted as the answer. However, you know, it's very interesting that these correlations with the triglyceride content of the cells and insulin resistance are so strong. And this is a theory that is supported by the results that a lot of us are seeing with clinicians with their patients, and then if you encounter individuals or you yourself may have this kind of experience, a low-fat diet actually is very effective in reducing the need for diabetes medication, as well as well, we'll get to that later. So then the other sort of theory that's out there is more of a liver-centric theory, and this theory is that there's lipid accumulation in the liver, which is interfering with this function, and then the liver dysfunction is leading to a whole body dysfunction. So there's excess liver lipid, and there's this feed-forward cycle. So you have this partial insulin resistance, and it's not suppressing the hepatic glucose output. So your liver is still putting out more glucose, even though you don't need it because you have plenty of glucose in the blood. At the same time as it is breaking down glycogen, it's also building up fat, which increases fatty liver. And then this is impairing the beta oxidation, so the burning of fat. So both of these are contributing to the fatty liver and then this whole body dysregulation of insulin and glucose. And then at the same time, there's development of inflammation with fat accumulation, which is fatty liver disease. So the fact that the liver is so prone to storing fat at the same time as this condition of inflammation is damaging the liver even further. And in non-alcoholic fatty liver disease, the ability of insulin to suppress lipolysis is really impaired. So this is like another theory that is sort of out there, and what both of these share in common is that they both relate to fat accumulation in the cell. And I think that an important principle of sort of more holistic nutrition is that the body is all one. So if you have excess fat in one place, you're likely to have it somewhere else. And some of the ways that the body inappropriately stores fat are not to necessarily distribute it evenly everywhere. So some people are more predisposed to storing visceral adipose tissue as opposed to ectopic fat. But at the same time, you know, there's excess fat in either or both of these organs, and both of them do have, they seem to have a role in causing this insulin impairment. And then, you know, what's really potentially significant about this is that in humans, there has been research looking at insulin-resistant but still lean subjects. So these are people that were diagnosed as insulin resistance with a family history, or sorry, insulin sensitive with a family history of type 2 diabetes, and then they had matched controls who were insulin sensitive. And they looked at their intracellular triglyceride content as well as their mitochondrial phosphorylation rates, which are, you know, a measure of how well the mitochondria are engaged in creating energy. And what they saw was that there was an 80% increase in this intramyocellular fat, although not in the intrahepatic triglyceride, but essentially in these insulin-resistant people, there was a lot more fat in their cells, and their mitochondrial phosphorylation rates went down by 30%. So this is pretty significant, because a lot of the typical management of diabetes is actually to eat a higher fat diet, to decrease carbohydrates, and to try to control glucose by eating low glycemic foods, and to not tax the insulin receptor cells with a greater need for insulin, but rather to, you know, reduce carbohydrates and really focus on higher protein and higher fat foods. But in this case, you can see that the mitochondria were compromised because of this, or it appears anyway, that the mitochondrial sort of a state of the mitochondria being compromised was associated with this much higher rate of fat stored in the cells. So this is really significant because, as I said, there's no strong consensus among researchers on a single etiology of type 2 diabetes. There are many potential factors and many pathways that I didn't really get into. But this immediate problem is the elevated glucose, and it is possible to manage that through medication and control of glucose intake and taking insulin. And, you know, a lot of people do have more stable blood sugars with low-carb diets and paying attention to the glycemic index. But there's really a lot of evidence that fat is implicated on a cellular level in the cause of dysfunction of both the insulin resistance and the beta cell dysfunction. And dietary fat is within the control of the patient. So that's what is really kind of exciting. Now, gastric bypass surgery, as I said, it's really taken off in the last 5 to 10 years. If you search for gastric bypass and diabetes in PubMed, I got 180 papers just from this year on this topic. And there's a lot of increased interest because you can get very rapid improvement in blood glucose following the surgery. And what I highlighted from this paper, which I will send you afterwards, is something that I find a little disturbing. It says, ample data confirm the excellent safety and efficacy of conventional bariatric operations, especially Roux-en-Y gastric bypass and laparoscopic adjustable gastric banding to treat type 2 diabetes mellitus in severely obese patients. Use of experimental procedures as well as conventional bariatric operations is increasingly being explored in less obese diabetic patients with generally favorable results. So what I've heard from the researchers that are more involved in this field is that these people are not healthy afterwards, but they're healthier than they would be with diabetes and being obese. So they're choosing, in a sense, the lesser of two evils, and because people are so desperate and really not sure how to address this problem, the popularity of this option is increasing. So I have I have this slide on the different types of gastric bypass surgery, just to, you may be very familiar with how this works, but if you're not, there are different types and they're increasingly extreme. So A is this vertical banded gastroplasy, and the stomach is partitioned with staples and then fitted with a plastic band to restrict the passage of food through the stomach. So the food goes through the stomach still, but there's a lot less space, so you can't eat as much. B is the adjustable band. So the upper part of the stomach is encircled with this constrictive saline-filled tube, and then the amount of restriction can be adjusted by injecting or withdrawing the saline solution. So they sort of put a bag in there to take up space, and then you can't eat as much because part of the space is taken up by this bag. In Roux-en-Y, which is not C, this is the most popular because they do get very rapid results, which we'll talk about. A surgical stapler is used to create this small gastric pouch. So the ingested food bypasses about 95% of the stomach, the entire duodenum, and part of the jejunum. So the stomach's about the size of a fist or a small couple fingers, and the food just goes through the stomach and then past the stomach and then right down into the jejunum directly. And a lot of these people have, and then the other two, as you can see, are kind of even more extreme, so they're bypassing even more of the small intestine. So a lot of these people do have nutrient deficiencies following surgery because a lot of the micronutrients are absorbed in the duodenum, which is the first part of the intestine. There isn't really a lot that they can do about that because that part of the intestine is gone. So these people do often need to take supplements just to avoid nutrient inadequacy, and they often are very uncomfortable, and they can have a lot of pain following the surgery, and they can have a lot of gastrointestinal discomfort just from trying to digest food. So here's a more simple diagram of the Roux-en-Y gastric bypass. So the normals on the left, and on the right you can see that the stomach and part of the duodenum and part of the jejunum are still there, but they connect to a lower part of the intestine, and then they sort of go up and don't go anywhere. It's like a dead-end street. So what you see, though, and the reason people are so excited about this, is that you do see very rapid resolution of type 2 diabetes, resolution of hypertension, improvement of blood lipids, particularly with the Roux-en-Y gastric bypass. You see like 97% of people, and this is from a meta-analysis with 136 studies and 22,000 patients. And then there's weight loss, of course, with all of them because they really can't eat very much. So these effects, what people like is that they seem independent of the weight loss, so they happen before people have lost weight, and they're also disproportionate to the weight loss. They're very rapid, and usually with like less than 3 days, they can get off of their diabetes medication. And then you see greater improvements in glucose homeostasis than after equal weight loss by other means. So there's something else that's happening besides just the weight loss. And, you know, these are, for some people, you know, they feel like this was worth it to them. And it is quite a significant thing to be able to discontinue medication. But there are some other aspects to gastric bypass. So that sort of hanging piece of intestine and stomach that leads up from where the intestine was cut and sewn, sort of dead-end street. You have protein putrefaction and fiber fermentation, so you really have material in there that's putrefying, and the gut microbiota is in terrible shape. It's really toxic. So that's a big downside. And people at this point, we don't know what the consequences are of having such a toxic microbiome in your intestinal tract. We really haven't had enough long-term research to be able to describe if this puts you at risk for anything else or how this might be affecting the rest of your gut. Gut hormones are changed, and you know there's really a lot. There's a lot more going on than simply reducing your caloric intake, and so a lot of these changes are, they can cause increased body odor, as well as a lot of pain or disturbance in digestion. So it's a very significant thing to undergo this surgery, and of course it is. I'm not aware that it's reversible, but it's quite permanent, and it's not completely permanent. And it's a really big deal, and I think a lot of the people that choose this option do feel desperate, and they do feel like there is no other choice for them. So I'm going to move on to caloric restriction, which is kind of hopefully a little less depressing, and it's kind of exciting because this is actually a way that you can achieve some of those same results, including the normalization of the beta cell function, meaning the beta cells started to secrete insulin normally again without that kind of extreme surgery. So this particular paper I'm going to talk about was called severe caloric restriction, so about 600 kilocalories per day. There also has been, similar results have been demonstrated with a liquid diet of about 1,200 calories per day over a longer period of time, and I'll send you both of these papers. But you can see that with this severe caloric restriction, you get really dramatic changes in insulin secretion after just 8 weeks. So panel A is the achieved plasma glucose levels in each group. Panel B is insulin secretion rates in the non-diabetic control group. So you can see that spike in insulin following a meal, and then it comes back down. And then panel C is the diabetic group at baseline, so you can see how their insulin secretion is not as high as the control group. Panel D is after just 1 week. It's already starting to come up. Panel E is the diabetic group after 4 weeks, and panel F is the diabetic group after 8 weeks. So you can, if you compare panel F to B, they're looking pretty much like the non-diabetic group. And this is after, again, 8 weeks of this severe caloric restriction. So this is really exciting because this was achieved with diet alone. And then this is also from the same paper. They had plasma glucose, hepatic glucose output, and hepatic triglycerides among the diabetics. So they saw that most of the improvement in fasting plasma glucose and in hepatic glucose output were achieved like within a week. And then the hepatic triglyceride content kind of went down gradually over the 8 weeks. And this is pretty interesting because it's so rapid for the first two, but you do see continuing benefit. And I don't know if they're quite sure like exactly why that was different, but these people also continued to lose weight over the 8 weeks too. So this is really exciting because there was no ongoing dietary input that was provided after this 8-week intervention study was over, but then they did check in with them 12 weeks later after the study had ended, and their mean body weight had gone down by 4 kilograms. This is among the calorically restricted group. And 3 of the 10 subjects that were retested had returned to a diabetic state based on the oral glucose tolerance test, but the other 7 were not. So despite the, the mean body weight increase. So they gained weight again after they stopped fasting. Their weight went back up. But 7 of them were still not diabetic, even though they had regained the weight after the 8 weeks. And so reversal, and this is actually, so the paper that did this caloric restriction is the Lim paper from 2011. But I also have this other paper that was sort of discussing this, and it's actually about gastric bypass surgery. And what they had to say about it was, it's the Knopp et al. Diabetes Care. Reversal of type 2 diabetes and restoration of normal beta cell function depends simply on reduction in intra-organ fat and liver pancreas, and this can be produced by dietary means alone. So that is really exciting, because I don't think that many people are aware that this is an option. It does work. And so I think that what we might want to talk about are some other paths to caloric reduction and low-fat diets. And I have a feeling that a lot of you might be relieved to finally see a picture of some food. So that's what we're going to talk about now. So there have been some studies that have given a vegan low-fat diet to type 2 diabetics. Dr. Neil Barnard has been a pioneer in really getting this research going, and I think that even 1 or 2 people on this call might have been involved in some of these papers. So he did a intervention randomized controlled trial with 99 subjects. 49 were put in the vegan group, and 50 were put in a American Diabetes Association control group. So this was initially 22 weeks, and the vegan group were instructed to eat in such a way that they would get 10% energy from fat. So this is a low-fat diet. It's much lower fat than what many research papers are referring to when they say low-fat. 15% protein and 75% carbohydrate. And the diet really just consisted of vegetables, fruits, grains, and legumes. Participants were asked to avoid animal products and added fats. So they were asked to avoid adding oil to their cooking, their salad. They were asked to avoid added fat. And then the ADA group was a typical diabetes-controlled management diet. So the composition of that was about 15 to 20% protein, 7% fat, and 60 to 70% carbohydrate. And then it was personalized a little bit with cholesterol based on body weight and plasma concentration. And then they did assess adherence. The diet was 24-hour recalls and interviews, and they looked at the nutrient composition to see how well these people were adhering to the instructions. So these are all free-living people. They didn't give them any meals. They did give them both a B12 supplement, but the only intervention they got was instruction on how to eat. And the vegan diet group was instructed to eat without portion size. So it was unrestricted. They could eat as much as they wanted until they were full. And the results were fantastic. So they kind of differentiated between the medication-stable subjects and the subjects who actually ended up reducing their medication. So if you looked at only the people who did not make any medication changes, hemoglobin A1C reduction was significantly more in the vegan group compared to the ADA group. There was a significant body weight reduction among all participants in the vegan group compared to all participants in the ADA group. And for those who didn't change their lipid medication, they had a significantly greater reduction in LDL in the vegan group compared to the ADA group. But what's also very exciting about this is that 43% of the vegan group and 26% of the ADA group did reduce their diabetes medication. So it's possible to achieve this, but this was not even, they were not fasting, and they also were probably not really eating such a low-fat diet as they were instructed to eat. But as you can see, these are changes that people are able to make in their lives without any special food and really without any provided food other than just the instruction in how to follow the guidelines. And they have published a number of other papers on this intervention. And the people in the vegan group, initially they had to get used to it, and there was a little bit of a learning curve, but at the end they were very happy and very satisfied with the diet and their experience. So then I just wanted to close with some other paths to caloric restriction, because I think that while giving people 600 calories per day in a research setting might be possible for most people living in their homes, that would be a very challenging behavior and also not a safe behavior to engage in without supervision. So I don't know if you're familiar with the True North Health Center, but Dr. Alan Goldhammer, who is one of the founders, is going to be a presenter at the Plant-Based Nutrition Healthcare Conference coming up in a couple of weeks. And he's a great speaker. And True North is really unique in that it offers medically supervised water-only fasting. And they do see and work with a lot of patients with a variety of conditions, including type 2 diabetes, who are very successful in getting off their medication. And for many people, this is a next step that allows them to get the support they need to make a kind of radical change in a safe environment. We do have MDs on staff who are supervising the patients, doing blood work and checking on them on a daily basis. And then they offer not just water, but they also offer totally whole food plant-based, no added oil, salt, or sugar food, so that when the patients begin eating again, they are able to wean themselves back onto a healthy diet. And just some of the extra benefits of this are that the taste preferences really change rapidly. I know that if you use plant-based nutrition already, you're familiar with how the taste preferences can change once you start eating a healthy diet. But they find there, when they add that fasting component in, it's even more rapid, and people are completely happy with the food after a brief fast, whereas when they got there, they couldn't believe they were eating anything with no salt in it. It just didn't really work for them. So I think this is something to consider if you are a physician and you need to refer your patient somewhere for a residential type program that would help them maybe jumpstart if they're going to go down the path of temporary only caloric restriction. This is a great facility, and I can't recommend them highly enough. And again, to go back to the conclusion that's really exciting from that caloric restriction intervention is that even though the subjects went back to their old diet and it was likely not a whole food, plant-based, very low-fat diet, 7 of them still were not diagnosed as diabetic after 12 weeks after that intervention ended. So there is a place potentially for short-term caloric restriction, and we just need a lot more research on all of this. But we can see that there's a lot of evidence implicating fat in the cells as having a role in the development of insulin resistance and beta cell dysfunction. And then we see in these interventions that both caloric restriction and simply eating a diet that has a different macronutrient composition, they both have very clear effects on plasma glucose. And so this is True North is something to consider as a path to refer patients and also for people that need to go somewhere where they can really be supported in eating the diet. So that's all we have so far for today, but I will be sending you the slides, and I'll be sending you all the papers that I was talking about, because there's so much to cover in this topic. I think I meant this just to be an introduction to the relevant research that I'm aware of, but I think if you have time, it's great to try and read those papers, and some of them might be very useful when you're talking to other people and sharing with them what is possible. So thank you very much. And I think we have a couple minutes, so I can take a couple questions if there are any.
Great job, Micaela. Thank you so much.
You're welcome.
Excellent overview. I'm not sure. Do you see any questions?
And yep, I'm checking. Yeah, I'm checking the chat window. So I think we might be. Yeah, I think we might be all set. I don't see any questions here, but thank you for your time. And I really, for those of you who are practitioners, I just really admire you in everything that you're doing for patients, and your pioneering spirit in using nutrition in your practice. So I hope this was of use to you in your work. And if you have questions later, I'm happy to answer them over email. But again, I will be in touch with all the materials after the webinar.
Well, thank you, Micaela. So on behalf of the Plantrition Project and PlantBasedResearch.org, we really appreciate you sharing this today, and thanks to everyone for joining us. So until next time, have a great day.
Sounds great. Thank you, Susan. I will see you in a couple of weeks.
I'll look forward to it. Thanks. Bye-bye.
Okay. Bye.